tried to make this very simple. It is called the PROTECT study. PROTECT study stands for Provincia Bios. That is the company which has been recently acquired by Sanofi, and it is a biopharmaceutical company for type 1D trial evaluating C-peptide with teplizumab. And so because I know there are many non-clinicians here, I've just kept it simple and tried to give a little bit of context, and I'm happy to discuss a little bit more of the protocol if required. It is based on an NEJM study. The NEJM website presents a 450-page protocol, of which, including the protocol revisions, and I went through the first part of the protocol. Elsa is a completely different study, but I have also tried to include a couple of slides on that. I was not sure it will be time for that. Okay. So now, when we are talking of the PROTECT study, we are talking of once diabetes has developed, so whether we can prevent it from worsening, or we can at least, or can we even reverse it. So for that, we have stages of type 1 diabetes, and I am telling the stages because based on this, the study has been taken. So stage 1 is when autoantibodies are there, but there is normoglycemia. Stage 2 is more than 2 autoantibodies with dysglycemia. Dysglycemia means when we do OGTT study, then the sugar is deranged, the glucose is deranged, but it has not reached the level of diabetes. And then stage 3 is the clinical one, where autoantibodies are also present. Mind you, many type 1 diabetes can present without autoantibodies also, but for the simplicity of presenting the study, it is autoantibodies present with hyperglycemia. Now, some people divide the stage 3 into preclinical and clinical, where you have antibodies present, you have hyperglycemia, but the patient or the child is asymptomatic, or it could be symptomatic requiring insulin. So these are the studies. Then why are the autoantibodies important? Because if there are 2 or more than 2 autoantibodies of type 1 diabetes present, then there is a 44% chance that the person will develop clinical type 1 diabetes in 5 years, up to 84% for 15 years. So if a child comes to me at maybe 7 years of age with 2 autoantibodies present, then 50% chance almost at 5 years there will be type 1 diabetes, or 15 years 80% chance there will be diabetes. And how I take it is that after 15 years also there will be 15% who do not develop type 1 diabetes. So why I find this important is that if we have a child who has autoantibodies positive, then there may be there obviously is a lot of concern, but there is also a 15% possibility that after 15 years also there is no clinical type 1 diabetes. And to me, I think I find it very important as a parent, as a doctor looking after a child with antibody positive, I need to tell them how important, how significant it is. So teplizumab is, what does it do? It is so CD3, these are the type 1 diabetes autoimmunity where beta cells is damaged. It is related to T cell autoimmunity, the CD3 cells. So the antigen, when the antigens are presented by the antigen presenting cells, they activate the CD3 cells, and the CD3 cells in turn cause beta cell damage amongst various other factors of damage which is there. So what is teplizumab? Teplizumab, it is a monoclonal antibody which is directed against CD3. So what happens? This does not. So when teplizumab is given, the T cells are not able to act, one of the mechanisms. So the beta cell destruction is supposed to come down. So it is a CD3 directed monoclonal antibody. Then it also causes some upregulation of the regulatory T cells based on we can say decreased activation of the CD3 cells and increased activation of the regulatory cells. The beta cell autoimmunity and the damage to beta cells is supposed to come down, and that is the pharmacology or the physiology behind it. So November 2022 in US, teplizumab, also called the Tzield, which is by Provincia Bio, this was first approved to delay the onset of stage 3 type 1 diabetes. So in this, children more than 8 years who were not already in stage 3, they did not have clinical symptoms or hyperglycemia. So they were relatives of children with type 1 diabetes who had autoantibodies positive, and these children were given teplizumab to see whether they are preventing. And because there was some significant results, so it was approved. It is also approved in 7 other countries, total 8 other countries. Now, so this was just the context. Now, if type 1 diabetes has already developed, can teplizumab prevent progression and protect the beta cells? This was the hypothesis of the this teplizumab study, which was published in NEJM 2023. This was a phase 3 trial evaluating whether teplizumab can preserve beta cells. Phase 3 trial means phase 1, phase 2, the dose has mostly been decided, it has mostly been found effective. Now these are usually the deciding studies which large number of population involved to see if it is effective. This was called the PROTECT study. So now, this happened between 2019 and 2023, almost like 2.5 to 3 years back. Multiple sites, 61 sites, USA, Canada, and Europe. It was a double-blind study, so the family didn't know if they're receiving teplizumab or the placebo, and the doctor didn't know if they're receiving placebo or the teplizumab. In the 2:1 ratio, so number of patients children who received teplizumab was double that of a placebo. Inclusion criteria: 18 to 17-year-olds who were diagnosed with type 1 diabetes. Within 6 weeks, they had to be put into teplizumab with at least one autoantibody positive, and they went a peak stimulated C-peptide level that had to be more than 0.2 picomoles per ml. So 328 children were randomly assigned, 217 to teplizumab and placebo 111. So more than twice in teplizumab than placebo. And 2 12-day courses of teplizumab were given 6 months apart. So, and they were followed up till 18 months. The primary endpoint was what is the C-peptide when we do a mixed meal tolerance test. So they're given some meal. The meal is supposed to increase the C-peptide, so whether it happened. And the secondary endpoints were clinical improvement, safety, quality of life questionnaires, and the pharmacokinetics, how the teplizumab works, and all the immunogenicity, all these studies were also done. Now, the difference between primary endpoint and secondary endpoint, if what is there, that when we devise a study, if something comes in the sample size is based on the primary endpoint. If anything comes a little bit positive in the secondary endpoint, because the sample size is not calculated for the secondary endpoint, so generally it is not taken as significant. This was the study. So here, within 6 weeks, they were randomized. Autoantibodies were positive. A 12-day course, and then 6 months later, and the second course. And because this was 2019 and COVID came in between, so some children received around 52 weeks instead of 6 months. So what was the result? So when this teplizumab was given, we are all talking of at the end of 1.5 years of teplizumab. So what was significant was the mean change from baseline. So you can see this teplizumab line and this is the placebo line. So the C-peptide mean change was minus 0.09, the LSM square, whereas the placebo declined more, minus 0.21. So this itself shows that the C-peptide level here, and because this was the sample size was adjusted for the primary endpoints, it was taken as significant that the teplizumab actually at least preserved the C-peptide in people receiving teplizumab better than the placebo, and that is quite significant. And if you look at this, C-peptide level more than 0.2 was around 95% of children receiving teplizumab had C-peptide more than 0.2, whereas 80% had of placebo had more than 0.2. The secondary endpoints, what they wanted to see was, okay, if C-peptide is increasing, is it changing the clinical parameters? So does the HbA1c change? Does the time in range change? Does the insulin requirement come down? And are there less hypoglycemias in teplizumab? They tried to look at the clinical factors of it. Is it clinically affecting that? And there was no significant difference. But if you look at the various things, So the values are actually tending towards more clinical improvement. Like teplizumab in almost 57% of children showed time in range was very good in against 47% in placebo. The insulin dose in children receiving teplizumab was lower in at all time points based against the placebo. The HbA1c levels were almost similar. The quality of life favored the teplizumab group. And basically it, if anyone wants to take a pic, yeah. So if basically it showed, yes, the C-peptide levels do not fall as fast as if they are not given teplizumab. Clinical parameters are little better, but they do not reach statistical significance. And the quality of life assessment domains, whether it is the pediatric quality of life, or whether it is the hypoglycemia fear survey, or whether it is the diabetes treatment satisfaction questionnaires, they all tended towards teplizumab, favoring teplizumab. So now, when this study was given, what were the adverse effects? Everyone wants to know about the adverse effects. Those are very important. So headache, gastrointestinal symptoms, rash, lymphopenia, they were all mild. They resolved spontaneously. They did not have any clinical significance which caused a problem. There were certain dropouts because of the adverse effects, and the dropouts were primarily because it was the protocol had it, but they were that if you reach that criteria, they have to be dropped out. But they were clinically all asymptomatic, and as we said, so there was 2 cytokine release syndrome like fever, chills, all these things which resolved within 7 days. And this complete list of side effects is also there for if anyone wants to see in details. The lymphocytes came down, but they all came up within 7 to 14 days. And so I would take it as that teplizumab showed benefits on beta cell preservation. And probably another thing which is probably comes out from this is that autoimmune damage to beta cells till now it's been like so many 100 years of diabetes, but probably one of the first studies which gives hope that autoimmunity to beta cell is modifiable or maybe preventable. Maybe one drug is not enough, maybe it can be a combination of drugs. At least we are going somewhere as to where the drugs are concerned, and further research should continue. So regarding a real world estimate of this teplizumab study, so there is another paper from the previous thing where they were given for the stage 2. And I think what people are hopeful that there could be something, but to everyone, and especially the support group people who are here, it is not yet there. But yes, there is hope that very soon something could come up and science is going on. I was a part of the NDA study in Sydney under Professor Maria Craig. She's one of the prolific researchers for type 1 diabetes. And I was involved in the cord blood study and the NDA study. And I know how difficult it is to do population studies, taking samples and recruiting people, counseling them. And it is very, very difficult. So, I mean, I think slowly we are getting there. So,
thank you very much for the nice